Okey. Bismillahirrahmanirrahim. Jalan tak? Okey. Assalamualaikum warahmatullahi wabarakatuh. Tak payah tekan je lah. And a very good morning to the fellow participants that are here. Okay. Alright. So we'll be talking about regarding the cost-benefit review in RA. So I was wondering why has this been picked as the first topic, but having to listen to what Brian mentioned earlier, then we realise this is where we want to focus RA to be beneficial in a whole holistic way. Because it's not about whether it's good or it's bad, but is it really cost-driven, and is it really giving us value? Okay. So as what Brian mentioned earlier, if you look in literature, sebenarnya when we talk about in anesthesia, I'm not talking about RA. In anesthesia, when we talk about cost analysis, there is very limited literature out there. And if there is any one, interestingly, it will be in the journals of Colombia, Brazil, and the Latin Americas. They are the ones who are publishing this. If you look in RAPM or even analgesia, most of this outcome looking at cost benefit is really related only part of a journal or systematic review as a secondary or tertiary outcome. So hence, this is where as we are looking forward into, we're looking about cost and the value of a particular procedure, that where this comes into picture. Okay, the three most common jargons when we talk about cost: cost effectiveness analysis, cost utility analysis, cost benefit analysis. It's not just your English word that you translate, but it has certain things where what is the measurement? What do you actually measure? Definitely you are measuring the cost, and what are the outcome that you are measuring on. For cost effectiveness, is actually in terms of your outcome, will be your clinical outcome. In terms of your cost utility, it will be multidimensional, and we talk about quality of life. Kali Andali. I hope the next speaker will talk about this, and also ISA. It's a very important jargon as well. And number three, the simple thing, the cost benefit. You compare money between two, the cost, and then you compare whether what it saves or is not in terms of monetary, and that is the outcome that we're looking at. Alright. So as I mentioned earlier, in literature, we cannot find properly something, but there is a recent review article which I thought was interesting, and of course in view with what Brian said as well, the role of RA and acute pain service in value-based healthcare. What is value-based healthcare? Tadi dia explain juga tadi, curi my slide. Value equals to outcome over cost. Okay? Usually we talk about value, kita always talk about our clinical outcome in RA, what is good, what is bad, faster, etc. But we have never really looked into, as this is not, ini bukan I yang define, this is been defined by Michael Porter. Michael Porter is the Harvard professor which starts off this in the US. Why? To bring out the different type of scheme of payment in terms of reimbursement in their healthcare system. So it's your outcome and cost. And outcome is it's a combination of the clinical outcome of your procedure or treatment or your intervention. And second is patient satisfaction. What patient perceive following the procedure intervention. So this has to be clear. And why we are moving forward is because usually even at I think KKM level or even hospital level, when we talk about how much it costs. Even in private, we talk of patient. If you do a lab quali, how much it costs. But we are not talking about what value it brings. But as everybody is aware, when we talk about IRAS, that is actually the outcome of IRAS. And by right, now we should be looking forward into the costing of that and looking its value and interpreting that in the system. Alright. So this particular paper, what it mentioned about the framework for in the triple aim of your value base, which is the intermediate effect, immediate effect, the medium term advantages, and your holistic outcome. So these three things are what the paper actually talks about in terms of looking at what is available online. When you talk about cost effectiveness, it relies on two concepts where it is indirect. We're not talking about which is cheaper. Nak beli mana? Payung lagi murah ke biberon lagi murah? No, it's not that. It's about the first concept. Basically, it's your faster recovery time that can be achieved with RA or any other measures, which is time saving that can be converted into valuable activities. That is value for money. For us, we're talking about accelerated workflow or you reduce your overtime. And second concept, it refers to the reduced expected complication, surgical and anesthetic. For example, respiratory complication, readmission. This is cost save. So these are the 2 points that we look at when we talk about cost benefit, cost effective, cost utility. Ladies and gentlemen, this paper actually mentioned the three type of sort of studies which you see in the 2023 systematic review, which is the biggest so far. And as you can see, tengok, siapa yang buat? Brazilian Journal Anaesthesiology. Dia orang rajin buat benda-benda macam ni. But as you can see from their systematic review, they would equate to the lower hospital total cost due to reduction in OR time, post-anesthesia recovery, shorter hospital stay. Again, another review with 8,000 patients, looking at what they look at, the reduced anesthesia control time. Okay, this particular study, the RAPM, we're talking about this block room. If you are into ESRA as we go, they are talking about block room. And how it relates to cost is actually very, very simple. Okay, the next particular 4 review that they have is all this study, and I think 3 of this study is talking about induction room or block room. Simple je how dia punya costing. In their anesthesia or surgery costing is about the time that you use the OT. So block room is somewhere outside the OT, whatever being done there tak kira. That's why you get all these savings on the left side. More than 10 minutes, more than 15, more than 20 minutes of saving time, and that equals to cost. Why? Your block of costing is how long you use the OT time. And this kira tak kira. And the efficiency because of the block room which is out of the flow system. So because it's not counted, that's why the block room is effective in the overall cost of a procedure or function. Ladies and gentlemen, at the last, the really studies that evaluate cost effectiveness, what is being pointed out in this paper will be all these 4 which directly calculate in terms of monetary. So obviously on all these 4, and its latest is 2019. From 2016, all these 3 or 4 particular reviews where what they look at here is the total money saved. Alright, so looking at all this, what does the article review actually tell us? It tells us that RA and pain service are crucial in value-based healthcare. Okay, as I mentioned, value-based healthcare, a simple example that maybe you all understand, we talk about IRAS. Alright, IRAS and the outcome. Kita tahu all the clinical and where RA comes into the picture. If without RA and multimodal, there's no way IRAS is going to happen, or not happen, has its benefit. Hence, it's actually that cost of particular era and the protocol that is being used. If we understand about protocol, we talk about like prospect for knee surgeries, etc. So that particular method that we use, that cost, and that is actually the value which will bring back to say, yes, this is what we want. Alright? So, number 2, studies that has been shown in this paper demonstrate that RA enhances patient recovery and operational throughout. As we all know, and there are so many evidence that we cannot deny the particular effectiveness or the particular advantages of clinical outcome. But when we really translate it into the cost in terms of value, okay, value equals to outcome over cost. That means if your cost is lower, mathematics senang je. Lower cost, but good outcome, bigger value. Simple maths, as simple as that. And as we can see now, if we look at value-based, which means that we know this program works and would ensure patient to have a satisfactory outcome, then that is the protocol or flow that we should use. It's actually simple when we talk about cost effectiveness. However, as you can see, for who are the ones benefit most when we talk about value-based healthcare? The patients, provider, payers, suppliers. Alright? So we talk about not just patient satisfaction, we talk about stronger cost control. That means you can maintain your control, and also your supplier, how much they can align with what being used, especially when it's guaranteed program or things that you do. But ladies and gentlemen, if you ask me, is this article really useful to us here? Honestly, not relevant to our current healthcare financing structure. Neither you or mine, neither government or private. Why? Because we are talking about fee for service, which means that how much of it costs. We are not talking about when the patients are all well, when we have this data, and how much that cost is really saving the government. Nobody talks about it at the moment, and this should be the paradigm change. Maybe this is what AME should bring in their meeting with our data, how the outcome is good and how we can translate it into money and show that if you follow this protocol, you will give these certain blocks together with the whole procedure, and also good surgeon who's a shorter time, that's ESRA punya main principle, then you would definitely save a lot of money as well as resources for the patient for better value. That's for the government. For private, currently, you say what is important for the patients is actually how much they pay lah. We still fees for service. But for health insurance provider, this is actually a very key point. If RA society can lead the point with their studies and things and bring into the health insurance provider the outcome that they want with a shorter cost, then you will be the one who will determining how much. But the disadvantage of that, it will limit, for example, a package. Dia boleh jadi another package where your package becomes okay, when you give anesthesia, you nak the cheaper package or the more expensive package. So that would be the question in point. Okay, I think that is all. Thank you very much.